A very good morning to all enthusiastic learners. I, Dr. Vaishali Vichare, Assistant Professor in the Department of Physiology, including Biochemistry, YMT Homeopathic Medical College, KHARGHAR. On behalf of Dr. G.D.POL Foundation, YMT Homeopathic Medical College, NAVI, Mumbai, welcomes you all for today's webinar on Hypothalamo-Hypophysial-Gonadal Axis. This webinar is organized in association with Department of Physiology, including Biochemistry, YMT Homeopathic Medical College, KHARGHAR. Reproduction is essential for the continuation of species preservation. It has been generally accepted in mammals that hypothalamo-hypophysial-gonadal axis plays an essential role in regulation of puberty and reproduction. Homeopathy has a lot of application in regulating this axis. From a homeopathic perspective, mind and body are seen as inseparable in order to understand the art of homeopathic case taking and the homeopathic art of healing. A homeopath needs to understand the underlying cause of disease at the different levels. Before starting the treatment, homeopath should understand the endocrine system and its effect on the body. One of the key links between the mind and body is the relationship between the nervous system and the endocrine system. Most of the problems in pubertal age and young adults are related to the HHG axis. Knowledge of this physiology is must while treating the cases. So we have selected this topic for today's webinar. Now let us introduce our today's speaker. Today our speaker, who is a senior faculty of YMT Homeopathic Medical College with lots of experience, gives an in-depth presentation of hypothalamo-hypophysial-gonadal axis. Dr. Aniruddha Joshi sir, he is graduated from BJ Medical College, Pune and completed MD also from the same institute. At present, he is working as professor, head of the Department of Physiology in YMT Dental College and as a guest professor in YMT Homeopathic Medical College, KHARGHAR. He is having teaching experience of more than 30 years in various institutes in India as well as in abroad. He has worked in different capacities on editorial board of studies and academic council of various universities. He has presented research papers in national and international conferences. He has many publications in scientific journals. He was among first 20 doctors who were selected for training in sports, Patiala. His educational DVDs on clinical physiology and animal physiology are reputed in India as well as in abroad. He is honored by National Academy of Medical Sciences for his work in the subject of physiology. I know that you all are eagerly waiting to gain the knowledge. So I am very glad to invite sir for today's webinar. Before starting the session, I would like to request you all, the audience, kindly mute their microphones during the session. And whenever questions or doubts arising to their mind, please drop them into our chat box, which will be answered by the sir in the question answer session after the lecture. So without taking much time, I would like to request Dr. Joshi sir to enlighten our knowledge. Sir.
Good morning, everybody. Before starting the topic, today's topic, that is hypothalamo-hypophysial-gonadal axis, let me thank higher authorities of G.D.POL Foundation Dr. Page Madam, her entire team, and Department of Physiology for arranging this academic activity. Such activities are definitely useful not only for undergraduates or postgraduate students, but they are helpful for teaching faculty also, so also for the practitioners. So it is really, madam, a good activity that our homeopathy college is conducting for the benefit of all. Now we will go to the today's topic, and that is hypothalamo-hypophysial-gonadal axis. All of you know hypothalamus is a part of the forebrain which is located below two thalami. Thalami are two. Below each cerebral hemisphere, there is one thalamus. And below two thalami, there is a single hypothalamus. How we remember hypothalamus? It is the smallest part of the brain having maximum functions. In our body, there are two control systems or regulating systems. Any physiological parameter you take, gastric juice secretion, heart rate regulation, blood pressure regulation, everywhere there will be a nervous regulation and a hormonal regulation. Hormonal regulation is mainly done by pituitary gland, and pituitary gland is under the control of hypothalamus. So even endocrine functions are also controlled by nervous system, and it is the main hypothalamus which is regulating almost all body functions. Hypothalamic functions, we divide them into two: endocrine functions and vegetative functions. Endocrine functions, which we will be learning it in details, are it controls anterior pituitary hormones, it controls posterior pituitary hormones, and it also controls adrenal medullary hormones. And along with these endocrine functions, certain vegetative functions, means which are essential for life, like food intake, thirst mechanism, temperature regulation, sex behavior, biological rhythms, they are also regulated by hypothalamus. We will be concentrating our attention for the endocrine function, and that also specifically related to control of anterior pituitary hormones. Hypothalamus secretes various factors. Either they are releasing factors or inhibitory factors, which go from hypothalamus to anterior pituitary through hypothalamo-hypophyseal portal circulation. When they reach anterior pituitary, its hormones are regulated by these releasing or inhibitory factors. Giving you an example, growth hormone, which is coming from anterior pituitary, will be under the control of growth hormone releasing factor as well as growth hormone inhibitory factor. Depending upon production of these two factors, growth hormone secretion will be regulated. Posterior pituitary hormones are basically hormones of hypothalamus only. Antidiuretic hormone or vasopressin and oxytocin, they are produced in hypothalamus only they are stored and released from posterior pituitary. So they are also under the control of hypothalamic nuclei. Adrenal medullary hormones are adrenaline and noradrenaline. They are under the control of sympathetic system, and sympathetic system is under the control of hypothalamus. So even those hormones are finally regulated by hypothalamus. As far as today's topic is concerned, hypothalamus, relation with pituitary, and then relation with the gonads, the link is like this. Hypothalamus secretes gonadotropin releasing factor, GnRF, which goes to anterior pituitary so as to control pituitary gonadotropins, namely FSH and LH. Then subsequently, FSH and LH, they will act on gonads. Gonadal function will be stimulated. So also sex hormones will be produced from gonads. So hypothalamus, GnRF, anterior pituitary, pituitary gonadotropins, gonads, and sex hormones is the link which we will be learning in our today's lecture. Pituitary gonadotropins are follicle stimulating hormone and luteinizing hormone. And the important point to be noted is these hormones are produced only after puberty. Other pituitary hormones like growth hormone or ADH, oxytocin, TSH, ACTH, all these hormones are produced even before puberty. But FSH and LH are not there before puberty. They are produced only after the age of puberty. That means hypothalamic factor, what we mentioned, gonadotropin releasing factor, GnRF, starts getting produced only after the age of puberty, both in males and females. Coming to the actions of FSH and LH, in males, FSH stimulates spermatogenesis, and in females, FSH causes formation of the ovum and estrogen secretion from developing ovum. Spermatogenesis in males and ovum formation, estrogen secretion in females is under control of FSH. We will see later on that we call here female function of FSH formation of the ovum and not oogenesis. For males, we call the term spermatogenesis, but for female, we don't call it as oogenesis. Why? The name is formation of the ovum. We will see it later. So formation of the ovum and estrogen secretion is done by FSH in females. Spermatogenesis is done by FSH in males, and both the functions are after puberty. When FSH is stimulating cells in the seminiferous tubules, those are spermatogonia for spermatogenesis, simultaneously Sertoli cells are also stimulated and they secrete a hormone inhibin, and this inhibin inhibits FSH secretion from anterior pituitary. So FSH stimulates spermatogenesis and Sertoli cells. Sertoli cells secrete inhibin, and inhibin causes feedback inhibition of follicle stimulating hormone. There exists a negative feedback between FSH and inhibin, so that levels of the hormones are kept within the normal limit. In females, FSH stimulates formation of the ovum and estrogen secretion. This estrogen coming from developing ovum inhibits anterior pituitary for FSH secretion. Estrogen coming from developing ovum inhibits pituitary for FSH secretion. This we call it as short loop negative feedback. Estrogen inhibiting FSH at pituitary level is short loop negative feedback. At the same time, estrogen inhibits hypothalamus for GnRF. Estrogen inhibits hypothalamus for secretion of gonadotropin releasing factor. This feedback is called long loop negative feedback. So estrogen will be regulating FSH secretion by both short loop negative feedback as well as long loop negative feedback. But remember, in males, for inhibin, there is only short loop negative feedback. Inhibin inhibits FSH from anterior pituitary. Inhibin has no effect on hypothalamus for GnRF secretion. Only short loop negative feedback for inhibin, but for estrogen, both short loop and long loop negative feedbacks are there. So this is about follicle stimulating hormone getting secreted in both males and females after the age of puberty. Coming to the second pituitary gonadotropin, and that is luteinizing hormone. In males, it is called ICSH, interstitial cell stimulating hormone. Luteinizing hormone in males or ICSH in males acts on interstitial cells of testes to secrete testosterone. Testosterone secretion is enhanced, increased under the effect of LH coming from anterior pituitary. LH in females causes ovulation. Ovulation occurs on 14th day due to mid-cycle surge, maximum level of LH. Ovulation occurs under the effect of LH, and subsequently corpus luteum is formed, which secretes progesterone. So ovulation and progesterone secretion in females is under control of LH. As far as LH regulation is concerned, there are existing both short loop negative feedback mechanism as well as long loop negative feedback mechanism. In males, when testosterone is secreted from interstitial cells, it inhibits anterior pituitary for LH secretion, and testosterone inhibits hypothalamus for GnRF. So both at pituitary level, short loop negative feedback, at hypothalamic level, long loop negative feedback. By that, LH secretion or ICSH secretion is regulated in males. In females, progesterone inhibits LH from anterior pituitary, and progesterone inhibits hypothalamus for GnRF. So again, both short loop and long loop negative feedbacks exist in female so as to control luteinizing hormone secretion. Between LH and testosterone, negative feedback. Between LH and progesterone, again negative feedback exists. LH stimulates testosterone, but testosterone inhibits LH. LH stimulates progesterone secretion, but progesterone inhibits LH secretion, so that hormone levels are kept within the normal limit. We will come to this point later on when we will be learning the applied importance of this axis, various hormonal therapies, what we will be learning. At that time, we will come to this point once again regarding the negative feedback mechanisms. Just to summarize functions of the testes in male, in testes, there are two separate tissues. One are seminiferous tubules and other are interstitial cells. Seminiferous tubules are lined by spermatogonia, which is germinal epithelium. This germinal epithelium divides under the effect of FSH after the age of puberty. First division is mitotic, second division is meiotic, and at the end, secondary spermatids are formed, which are containing haploid number of chromosomes. So some spermatids will be 22 plus X, some spermatids will be 22 plus Y. We call them as X spermatids and Y spermatids. They are formed under the effect of FSH in seminiferous tubules. LH acts on interstitial cells to secrete testosterone, and this testosterone is responsible for all pubertal changes in male. We will be learning all those actions of testosterone also. So pubertal testosterone secretion occurs in testes under the effect of luteinizing hormone. Seminiferous tubules are also lined by Sertoli cells. See, spermatogonia are different, Sertoli cells are different. Spermatogonia is the germinal epithelium concerned with formation of the spermatids and subsequently sperms. Sertoli cells are altogether different and their structure is also different. They are having long foot processes. These foot processes are attached to each other. What these Sertoli cells are doing, those spermatids, secondary spermatids, which are formed by the process of spermatogenesis under the effect of FSH, they are round. And if cell is round, it can't move. Unless it will develop a tail, then only sperm will be able to move. So round secondary spermatid is converted to elongated sperm by Sertoli cells. And this process is called spermiogenesis. So Sertoli cells are basically concerned with spermiogenesis. Round secondary spermatids are converted to elongated sperm so that sperm gains motility. Similarly, they also supply nutrition to the sperms for maturation to take place. Sertoli cells are endocrine cells. They secrete various hormones. The important being inhibin, what we mentioned earlier. Inhibin inhibits FSH from anterior pituitary. FSH stimulates spermatogenesis. At the same time, Sertoli cells secrete inhibin hormone. That inhibin inhibits FSH at pituitary level. Sertoli cells also secrete androgen binding globulin, which is required for maturation of the sperms. And they also secrete Mullerian regression factor in intrauterine life so that male genitalia they develop. It is curious to know that every fetus wants to become a female. But if Mullerian regression factor is there in intrauterine life coming from fetal testes, then that Mullerian system, which is likely to develop female genitalia, gets dissolved and male genitalia develops. If MRF is absent, fetal testosterone is absent, female genitalia develop. If fetal testosterone is there, fetal Mullerian regression factor is there, that Mullerian system gets dissolved and male genitalia develop. So for development of the male genitalia in fetus, this Mullerian regression factor is essential, and that is produced by Sertoli cells. Sertoli cells are having long foot processes and they are tightly attached to each other. And in between, when spermatogenesis is occurring, these foot processes are broken and secondary spermatids are pushed into the lumen of the seminiferous tubules. These foot processes, they develop blood testis barrier. Just like in brain, there is blood-brain barrier so that harmful substances from blood should not reach to the brain. In the similar way, there is a blood testis barrier which is formed by Sertoli cells. But remember, this barrier is not from blood to testis, rather it is from testis to blood. Sperms will be remaining in seminiferous tubules, epididymis, vas deferens for months together before they are ejaculated. Sperms are having their own metabolism, and certain metabolic products which are produced by sperm metabolism should not enter our blood because they are harmful to our body. So those products of sperm metabolism are not permitted to enter our blood because of this blood testis barrier. Rather than blood to testis, it is from testis to blood. So products of sperm metabolism should not enter blood. These are some functions done by Sertoli cells. All of us, we know testes, they develop high in abdomen, close to the kidneys. In intrauterine life, testes develop high up in abdomen. And then at the time of birth, they are pulled down through inguinal canal into the scrotum by rete testes. Rete testes are the fibers which are pulling these testes down into the scrotum. It is absolutely must, because spermatogenesis occurs always at a lower temperature. Our abdominal temperature is high, and at higher abdominal temperature, spermatogenesis can't occur, of course, after the age of puberty, and therefore testes are naturally only pushed out of the abdomen. Scrotum is lined by skin. That skin will have sweat glands. There will be continuous sweating taking place, and because of the evaporation of the sweat, temperature of the testes is always kept low than abdominal temperature, and this low temperature of the scrotum facilitates spermatogenesis. If testes remain in abdomen, they can't produce sperms. Abdominal testes can't produce sperms. But remember, testosterone secretion will not be affected. It doesn't need any specific temperature. Testosterone secretion will continue, but spermatogenesis can't occur if testes remain in abdomen. Important point to be kept in the mind of doctors: when all of us we go for school medical checkup, it is duty of the doctor to check whether testes are descended down in the scrotum or not. Most of the time we see how medical checkup is conducted in the school. People are standing in the queue, students are standing in the queue, doctor is sitting on the table, putting the stethoscope on the heart, and next candidate. Rather than checking for the heart sounds or auscultation of the heart, more important at that age is checking of the scrotum, whether testes are descended down in the scrotum or not. Because if it remains unnoticed, and say when that child becomes adult, and at that time we come to know that testes are still in abdomen, by that time all seminiferous tubules are fully destroyed due to the high temperature, and now spermatogenesis will not be possible. If undescended testes are detected at the time of school medical checkup, before reaching the age of puberty, by consultation with the parents, doctors, surgery can be performed, testes can be taken down into the scrotum, so that after the age of puberty, spermatogenesis will occur normal. Otherwise, if that thing gets unnoticed, that male will have lifetime infertility. Testes cannot be transplanted from one person to other, and once seminiferous tubules are destroyed, they are destroyed forever. So it is the point to be kept in the mind that all doctors who are going for school medical checkup, they have to check scrotum for descent of the testes. Absolutely must. And another thing, they should look for phimosis. If phimosis is there, again consult the parents, and circumcision is to be done, because afterwards that small hole will become inadequate for the passage of the urine. Urinary retention can also occur, and subsequently after reaching the adulthood, intercourse will not be possible with that phimosis. That's why these are the two important things doctor has to check while doing school medical checkup. Check for the testes descended down in the scrotum, and check penis whether there is phimosis or not. This is regarding the male organs concerned with reproductive function. Now coming to the female reproductive life, all of us we know the terms menarche and menopause. Menarche is the age at which menstruation starts, and it is nothing but age of female puberty. Female age of puberty is little younger than males. Male puberty for Indian boys is about 14 to 16 years. For Indian females, pubertal age is 12 to 14 years. So menarche occurs at the age 12 to 14 years. It is the age at which menstruation starts. Age at which menstruation stops completely is menopause. Reproductive life of the female gets over, and that age is 45 to 50 years. Between menarche to menopause is female reproductive life. Reproduction is possible between menarche to menopause only. And this life, reproductive life, between say about 14 years up to 45 years, is divided into number of cycles each cycle lasting for about 28 days. And these are called female reproductive cycles. In that entire reproductive life, about 450 to 500 such cycles they take place. And in every cycle of 28 days, there are changes occurring in ovary and there are changes occurring in uterine endometrium. Ovarian changes are two. One is formation of the ovum and second is release of ovum or ovulation. And uterine changes are nothing but menstrual cycle consisting of proliferative phase, secretory phase and menstrual phase. Now coming to the ovarian changes. Here I will explain it to you. While learning FSH, we mentioned action of the FSH is formation of the ovum, and we don't call this as oogenesis. Why it is so? Oogenesis starts in intrauterine life. When that female fetus is growing in the uterus, in intrauterine life only, oogenesis starts. And that oogenetic division is arrested halfway, late prophase or early metaphase stage. That oogenetic division is arrested at the time of birth and it remains arrested only till the age of puberty. So oogenesis is right from intrauterine life and that is not under the effect of FSH. That's why what action of FSH is having after puberty, we call it as formation of the ovum. Oogenesis has started in intrauterine life only and it is arrested halfway at the time of birth. In both the ovaries, such halfly arrested divisions are there in numerous follicles, and these follicles are called embryonic follicles. In all embryonic follicles, hundreds of follicles will be there in one ovary, hundreds of follicles are there in another ovary, and in all these follicles, which are called embryonic follicles, division is arrested halfway. After the age of puberty, when FSH starts getting secreted from anterior pituitary, it acts on these embryonic follicles. That halfway arrested oogenetic division is completed and oocytes are formed. So only that completion of the division is done by follicle stimulating hormone. Oogenetic division gets completed, secondary oocytes are formed which are containing haploid number of chromosomes. All secondary oocytes will have combination 22 plus X. All ova or all oocytes are 22 plus X. We learned sperms, some are X, some are Y. So it is the male who decides the sex of the child and not the female. It is the sperm. If X sperm combines with ovum, it will form female. If Y sperm combines with ovum, it will form male. Sex of the fetus is decided by male and not by female. As in illiterate community, female is being blamed for that. It is the male who decides the sex of the child. Ovaries work alternately. There are two ovaries. In one cycle, left ovary will work. In another cycle, right ovary will work. In every ovary, there are so many embryonic follicles, but only one follicle responds for the action of FSH. And in that embryonic follicle, now we call it as Graafian follicle, division gets completed to form secondary oocytes. Secondary oocytes formed are many. Out of them, only one grows further to form ovum. All other oocytes, secondary oocytes, they degenerate. So ovaries work alternately. Whatever ovary responds, only one follicle responds from that ovary. Out of so many secondary oocytes, only one oocyte grows further to form ovum. So finally, it is only one ovum produced per cycle. It is all miracle. Female herself is a miracle. We can't understand her. So her physiology also is difficult to understand. Who stimulates oogenesis in intrauterine life? Really, we don't know. How ovaries work alternately? Really, we don't know. How or which follicle has to respond in a particular cycle? We don't know. And out of so many oocytes which are formed, which will further grow to form the ovum, we really don't know. These are all miracles in the physiology of female, but finally the net effect is only one ovum is formed per cycle in that follicle. Now this ovum is inside the follicle. It has to get released, and that process is ovulation. Ovulation occurs on 14th day of the cycle. On 14th day, LH levels are maximum, and we call that as mid-cycle surge. Surge means maximum levels. At the middle of the cycle, LH levels are maximum. That mid-cycle surge causes ovulation, means breaking of the follicle to release ovum. Now, how this occurs, this is known, that how breaking of the follicle occurs, that physiology is known. But formation of the ovum, physiology is still a mystery. When LH is acting on follicular cells, it causes secretion of progesterone. And progesterone is a vasodilator substance. It causes vasodilatation of that Graafian follicle, and when blood supply increases, naturally tissue fluid formation increases, and fluid gets filtered in that Graafian follicle. Fluid goes on increasing inside the follicle, and follicular wall gets stretched. Progesterone, which is locally produced from those follicular cells, stimulates proteolytic enzymes like hyaluronidase. And that hyaluronidase enzyme breaks the protein wall of the follicle. Already follicle is full of fluid containing that ovum. When wall breaks, along with the fluid, ovum gets drained out of the follicle. Locally produced prostaglandins in the follicle do play a role in the release of the ovum. And because of these prostaglandins, many females, they get mid-cycle pain in abdomen. And that mid-cycle pain in abdomen is related with prostaglandins which are produced locally in that follicle. So basically LH subsequently produce progesterone and prostaglandins. They are responsible for breaking of the follicle and release of the ovum. Ovum gets released into the peritoneal cavity. Fimbrial end of the fallopian tube has ciliary epithelium, and those cilia are in continuous state of motion. So currents are produced in the peritoneum so as to attract that ovum released in the peritoneal cavity. So ovum will reach to the fimbrial end, it will enter the fallopian tube, and subsequent movement of the ovum is by peristaltic wave in the fallopian tube. If at all fertilization has to occur, it occurs somewhere in the fallopian tube, and then fertilized zygote reaches the uterus. If in the uterus, if favorable environment is there, like secretory phase, then that zygote will get implanted. If favorable environment is not there, then it will be thrown out along with the menstrual flow. These are two ovarian changes occurring during female reproductive cycle. Formation of ovum is controlled by FSH. Release of ovum is controlled by LH. Simultaneously, in the uterine endometrium, changes are occurring. When ovum is getting formed, that developing ovum is producing estrogen. and those estrogen hormones are coming through blood to the uterine endometrium, and under the effect of estrogen, endometrial growth is enhanced. Proliferation itself indicates endometrium shows proliferative growth, layers are added, blood vessels also grow, uterine glands also grow. So proliferative phase is due to estrogen, which is coming from developing ovum. Proliferative phase lasts for 10 days. After that, mid-cycle surge occurs, ovulation occurs, and corpus luteum is formed. Corpus luteum secretes progesterone. Progesterone comes through blood to uterus and is responsible for secretory phase. As the name indicates, in the secretory phase, endometrial glands are maximally active. They are producing a lot of mucus in the lumen of the uterus. It is vasodilator. So blood vessels of the uterus are dilated. Congestion of the uterus is taking place. Simultaneously in the cervix, whatever mucus was there in the proliferative phase gets liquefied. And in vagina also, there are some secretory changes. During this secretory phase, which is lasting for about 14 days, there are some systemic changes also occurring in the female body. That progesterone is like aldosterone, causes retention of sodium and water. So because of that, ECF volume, blood volume increases, female gains weight, there is discomfort in the breast, there is pain in the pelvic region, and there is high mental irritability. High progesterone level increases neuronal excitability. So it is observed that during this phase, mental irritability is more. All these symptoms, female suffering, is called premenstrual syndrome, PMS. It is individual specific. Some may feel, some may not feel, but some females do experience all the changes just prior to the menstruation. Secretory phase is by progesterone coming from corpus luteum and lasts for 14 days. If there is no fertilization, then ovum degenerates. Corpus luteum also degenerates to form corpus albicans. When ovum degenerates, estrogen level falls. When corpus luteum degenerates, progesterone level falls. Fall in estrogen progesterone, basically fall in progesterone is responsible for menstrual phase. What we mentioned earlier, progesterone is vasodilator. It is increasing the uterine blood flow. When progesterone level falls, now vasoconstriction occurs. And because of that, blood supply to that grown endometrium is cut off. Endometrium undergoes ischemic damage, and that ischemic damaged endometrium separates from basal layers. Along with that, mouths of the blood vessels are broken, so blood vessels bleed. So mucus, desquamated epithelium, blood, unfertilized ovum, all these products are thrown out as a menstrual flow for about 4 days. Total quantity is about 50 to 60 ml. Out of that, half is blood. And usually this menstrual blood contains large amount of fibrinolysins. And these fibrinolysins, which are coming from that dead endometrium, they dissolve fibrin threads. And because of that, in healthy state, menstrual blood never clots. Menstrual blood never clots because it contains large amount of fibrinolysins from that dead endometrium. If clots appear in menstrual flow, once in a while is okay, but if every time if clots start appearing in menstrual flow, it indicates heavy menstruation, and that female needs consultation with gynecologist Otherwise, she is likely to develop anemia. Normally, menstrual blood should not clot. During menstrual phase of the menstrual cycle, uterine musculature is made sensitive for the action of oxytocin, and that oxytocin contracts uterus and helps in evacuation. So menstrual pain is again due to oxytocin contracting the uterus like labor pains, and also prostaglandins locally produced in the uterus are also said to be responsible for the menstrual pain. And the common medicine that is recommended is aspirin for the menstrual pain. Aspirin is prostaglandin antagonist. So prostaglandin production is inhibited, and because of that, menstrual pain can be relieved. This is the important most diagram to understand hypothalamo-hypophysial-gonadal axis in the female. As cycle starts, FSH levels start rising. FSH causes formation of the ovum in ovary. Ovum secretes estrogen. Estrogen is responsible for proliferative phase. So when in the ovary, ovum is getting formed, simultaneously in the uterus, proliferative phase is going on. Ovulation occurs at the junction of proliferative and secretory phase. Due to that mid-cycle surge of LH, corpus luteum is formed. Corpus luteum secretes progesterone. Progesterone is responsible for secretory phase of menstrual cycle. Proliferative phase by estrogen coming from developing ovum. Secretory phase is by progesterone coming from corpus luteum. If there is no fertilization, ovum and corpus luteum degenerate, estrogen progesterone level falls. Fall in progesterone is responsible for menstrual phase of menstrual cycle. Proliferative phase by estrogen, secretory phase by progesterone, menstrual phase is due to fall in estrogen progesterone level. Counting of the days is to be done from the day of menstruation and not from the proliferative phase. Suppose today menstruation has started, it is the first day of the next cycle. If today menstruation has started, it is the first day of the next cycle. Counting is to be done from the day of menstruation. So 4 days menstrual phase, 10 days proliferative phase. That is how ovulation occurs on the 14th day of the cycle. Otherwise, question will come in the mind, proliferative phase is of 10 days only. And how we are calling it as 14th day? Counting is done from the day of menstruation. So 4 plus 10, that is how day of ovulation is the 14th day. Ovarian and uterine changes are linked with each other. When ovum is getting formed, simultaneously proliferative phase is going on. Then ovulation occurs. Then corpus luteum is formed. Simultaneously secretory phase occurs in the uterus. And when corpus albicans is there, ovum is degenerating somewhere in the fallopian tube or in the uterus, menstrual phase is taking place in the uterus. That is how these events are linked with each other. Cause of the puberty, we already mentioned age of male and female puberty. Cause of the puberty is awakening of hypothalamus. Someone has put an alarm in our hypothalamus. It starts ringing in male between the age 14 to 16. In females, that alarm rings between the age 12 to 14. That alarm starts producing GnRF. GnRF comes to pituitary, starts producing FSH-LH, and then subsequently gonadal development and gonadal function occurs. So awakening of the hypothalamus is the cause of puberty. Puberty, we define it as, it is the age at which gametogenic function means formation of the sperms in male, formation of the ovum in the female, that has to reach optimum, and at the same time endocrine function of the gonads also has to reach optimum, because then only sexual act will be performed and reproduction will be possible. So it is the age at which gametogenic function and endocrine function of the gonads reaches to such a level that reproduction is possible, that is age of puberty. Both gametogenic function and endocrine has to be there. Only gametogenic function is there, sperms and ova are produced, but sex hormones are not there, then sexual act will not be possible. So no pregnancy possible. And other way also, if sperms are not produced, ovum is not produced, but hormones are good, as it occurs in that undescended testes, then also reproduction is not possible. So both gametogenic and endocrine function has to reach optimum, and then only reproduction is possible. That is the age of puberty. It is due to awakening of hypothalamus. All changes occurring in male at the time of puberty are due to actions of testosterone. Testosterone is by LH, LH is by GnRF. So hypothalamus, pituitary and gonadal testosterone is responsible for all pubertal changes in the male, like development of internal, external genitalia, secondary sex characters like breaking of the voice, development of hair on face, axilla, pubic region, masculinization, anabolic changes, gain in the weight, epiphyseal fusion preceded by growth spurt, increase in the height of that boy, scalp hairline goes back leading to frontal baldness, acne formation on the face aggravated, erythropoiesis stimulated. That's why males are having more RBC count than females. Bones are mineralized, calcium is deposited on bones, semen formation begins, sex desire develops, and there are certain behavioral changes like aggressive behavior and attraction towards opposite sex. These are all pubertal changes occurring in the male due to testosterone produced after the age of puberty. Sex desire develops because testosterone is having action directly on limbic system of the brain. Night emissions and masturbation is absolutely physiological. Many people are having so many confusing things regarding these two mechanisms. Ejaculation of the semen occurs in dreams in that pubertal boy is absolutely physiological. It is one of the pubertal change only. And feeling for doing masturbation is also absolutely physiological. It is not at all any abnormality in that boy. Both the changes are absolutely physiological, and same is about the attraction towards opposite sex is absolutely physiological. Rather, if it is not occurring at that age, it is abnormal. One can say it like that. It is bound to be physiological at that age. Pubertal changes in the female are due to effects of estrogen and progesterone. Again, both internal and external genitalia develop at the time of female puberty. Menstruation starts, secondary sex characters they develop, breast development occurs, female gets a feminine look. Again, here also there is a growth spurt, increase in the height, followed by fusion of the epiphysis. Mineralization of the bones is important action of estrogen. Atherosclerosis is inhibited by estrogen. These are two advantageous actions of estrogen in that female who is having adequate estrogens. Mineralization of the bones and atherosclerosis inhibited. Skin is made smooth and oily. Sebum comes out very freely. Ducts are kept open. Skin is smooth, oily in female. Male skin is rough because testosterone makes sebum thick, and because of that sebum doesn't come out. Acne formation is precipitated in male. In females, usually acne will not be there because sebum is coming out very freely. Only few females they get acne. You must be knowing all all of you must have learned it in physiology. Some females are estrogen dominant. Rather, majority of the females are estrogen dominant and few females are progesterone dominant. Estrogen dominant females will not get acne. Their skin is more smooth, oily. Those females who are progesterone dominant, they only get acne. Progesterone has got action similar to testosterone. It makes sebum thick and acne formation is precipitated in those progesterone dominant females. At the time of puberty, even in females, there are behavioral changes. Literature mentions shy behavior, but I really doubt about it. And of course, attraction is there towards the opposite sex. Direct action of sex hormones on hypothalamus and limbic system causing all these behavioral changes. Male puberty is due to testosterone. Female puberty is due to estrogen and progesterone. Pubertal delay is very known fact, and there are so many factors which are responsible for delayed puberty. Vigorous athletic training during that age delays puberty. It is known in athletes that their pubertal age is late. High mental stress for that boy or girl, bad relations with parents delays puberty. High mental stress and relations with parents, if they are not good, that puberty gets delayed. In cold countries which are close to the poles, they are having delayed puberty, while those countries which are warm near equator, they are having early puberty. So climatic temperature do affect the age of puberty. Malnutrition, starvation delays puberty. Endocrinal disorders like hypothyroidism, juvenile diabetes delays puberty. Chronic diseases like tuberculosis in that boy, pubertal boy or girl, will also delay puberty. These are all causes of delayed puberty. When in clinical practice, any boy or girl is brought by parents due to delayed puberty, these are the things to be suspected first before going for hormone levels in the blood. These factors are more common rather than inadequate formation of the hormones. Early puberty is that way very rare. If there is sex hormone secreting tumor in the gonads, for example, estrogen secreting tumor is there, and then estrogen is being secreted at the age of 9, then that girl will develop pubertal changes at the age of 9. Similarly, if testosterone secreting tumor is there in the testes, producing testosterone at an early age, then all pubertal changes will occur in that boy at an early age. But these gonadal tumors are that way rare, and that's why early puberty is a rare entity. Delayed puberty is very, very common. And these are the common causes of delayed puberty. Hypothalamo-Hypophysial-Gonadal Axis gets affected in all these cases. If testes remain in abdomen, undescended testes or cryptorchidism, sperms will not be produced, leading to male infertility. Viral infections like mumps, they destroy seminiferous tubules. Spermatogonia, germinal epithelium is destroyed by mumps virus and may lead to infertility. If mumps has occurred during childhood, immunity is lifelong. So there is no risk of infertility in that boy. But if mumps doesn't occur in childhood, vaccine is not taken for mumps in childhood, then an adult person is likely to develop mumps, and that adult mumps will destroy testes because testes are functioning at that age, and then infertility is possible. Exposure to high temperature decreases spermatogenesis. So those who are working at high temperature, like furnace workers, they suffer from infertility. Heavy metal poisoning, lead, arsenic, bismuth, these are the heavy metals they are present in groundwater. So those who are drinking borewell water for long time and close by some industries there who is disposing their industrial waste in the ground, then this drinking water gets contaminated with heavy metals and people, they get infertility. A known cause of infertility close to certain industries, it is being found due to the heavy metal poisoning. Block in the vas deferens due to sexually transmitted diseases like gonococcal infection also leads to male infertility. And the simple test to detect male infertility is the sperm count by semen examination. When couple comes with infertility, male is to be investigated first because it is a very simple test to detect male infertility. Sperm count is to be done in that semen. Normal sperm count is 80 to 120 millions per cubic millimeter. More than 80% sperm should be mobile and there should not be any abnormal sperms. Under the microscope, when we check count, we check for motility and we look for abnormal sperms. If those things are there, if sperm count is less than 30,000 or rather 40, some people they consider it as 40,000 below, it is called oligospermia. Sperm count 0 is called azoospermia, leads to infertility. If motility is less, then also it leads to infertility. And abnormal sperms, sometimes if they are there with double head or without tail, then those abnormal sperms also lead to male infertility. So these are the things to be looked under the microscope. It is really curious, one should be curious to know, actually one sperm is required for fertilization. But when count falls below 40,000, 40 millions per cubic millimeter, infertility results. When sperm count falls below 40 millions per cubic millimeter, infertility results. That means if count is more than 40 millions, then only one sperm is able to reach to the ovum so as to cause fertilization. If count is less than 40 millions, sperm can't reach to the ovum and that leads to infertility. In female infertility, commonest cause in India is tuberculosis of endometrium, subsequently spreading to fallopian tubes, leading to tubal block. Viral infections like mumps also destroys ovarian epithelium, may lead to infertility. Uterine infections, again sexually transmitted diseases, and certain congenital defects in the uterus like bicornuate uterus, septum in the uterus, retroverted uterus, that may lead to female infertility. And nowadays, cause increasing for female infertility is polycystic ovarian syndrome. That is nowadays commonest cause of female infertility. Female is always to be investigated later. After male sperm count comes normal, then only we start investigating the female. We investigate her for tests for ovulation. We investigate her for ultrasonography to check uterine abnormalities, fallopian tube or not. And we do hysterosalpingography to check the patency of the fallopian tubes. By these tests, female is investigated for infertility. The commonest test, what is practically done to detect ovulation, those who are doing clinical posting or those who have done internship, they must be knowing, we do D and C. That is the best or 100% reliable test to detect ovulation is occurring or not. Ovulation occurs only after that LH surge, and only after ovulation corpus luteum is formed. Corpus luteum secretes progesterone and then only secretory changes occur in the uterus. So what we do in that D and C or endometrial biopsy, just day prior to expected date of menstruation, we call female in the hospital, local anesthesia is given to dilate the cervix and endometrial piece is scrapped and it is studied under the microscope. If endometrium shows secretory changes, means she is ovulating. If secretory changes are not there, she is not ovulating. So endometrial biopsy just prior to the day of expected date of menstruation is the 100% reliable test. And the same sample, you can send it to microbiology department to find out the cause of that is tuberculosis. We send the same endometrial specimen for checking for tuberculosis. So even cause of infertility will be found out. So not only ovulation will be detected, but if there is a endometrial tuberculosis, fallopian tube tuberculosis, even that will be detected with the same sample which is taken, sent to microbiology department. Of course, other tests are there. Basal body temperature chart is a non-invasive test. Similarly, ultrasonography is also non-invasive test, but they are not that reliable. Even laparoscopic examination can be done to catch the event of ovulation, but for how much time you are going on searching for that event? It can occur on 12th day, it can occur on 16th day. Doctor can't go on doing laparoscopy for a long time. That's why other tests, even though they are there, they are not practicable. The most practicable test is endometrial biopsy, or what we call D&C. Infertility management depends upon the cause. Depending upon the cause, we treat it. If ovulation is not occurring or spermatogenesis is not occurring, sperm count is low, then we give injections of gonadotropins, or our allopathic medicine, clomiphene is there. It is nothing but pituitary gonadotropin only. It stimulates formation of the ovum. It stimulates spermatogenesis in male. So if that is the defect found, sperm count low, ovulation not occurring, we give pituitary gonadotropins. That is to stimulate gametogenesis both in male and female. Certain surgical procedures will be required if uterine abnormalities are there. Retroverted uterus, septal uterus. Then some minor surgical procedures are done. That septum is cut, that uterus which is retroverted, we bring it to the normal position, and then pregnancy may be possible. If tubes are blocked, then there is the next step is to be done is in vitro fertilization or artificial insemination. Sperms of the male are taken, ovum from the female is taken, in vitro fertilization is done, and that fertilized ova are put into the uterus during the secretory phase. And then that will grow and it will lead to pregnancy. So if tubes are blocked, really we can't do anything. Then there is no choice but to go for in vitro fertilization. And if uterus is also abnormal, then there is no way out but to look for surrogate mother. Again, here we do fertilization outside the body, and fertilized ova are put in the uterus of some another female, which we call her as surrogate mother. She will grow the baby. Ovum is given by mother, sperm is given by father, but baby is grown by another female, and then after delivery, baby is handed over to the couple. So these are other options left. Depending upon where is the defect, we go for it. Hypothalamo-Hypophysial axis has got lot of application in clinical practice. Oral pills are given as a method of contraception. Oral pills, they contain estrogen and progesterone. Those are the classical pills, 28 tablet pack, 21 true, 7 false. Estrogen and progesterone combination is used in these classical pills. How axis is getting affected? Estrogen in the pill inhibits FSH. Progesterone in the pill inhibits LH. So we are blocking ovarian changes. Ovum formation is blocked and therefore there is no question of fertilization. That is how oral pills work. For emergency contraception, we use heavy dose of progesterone. It blocks LH, and because of that, ovulation is blocked, pregnancy prevented. If fertilization has already occurred and emergency contraceptive progesterone is taken, it is a heavy dose of progesterone. It makes uterine endometrium unfavorable for implantation. So in first 14 days, if unprotected sex is there, female takes emergency contraception, ovulation is blocked. If intercourse is done after 14th day, now more risk of pregnancy. By giving emergency contraception, heavy dose of progesterone, we make environment unfavorable for implantation. And that is how pregnancy will be prevented. In cases of stillbirth, to suppress milk secretion, we use estrogen. Prolactin action on the breast is blocked by estrogen, so that milk secretion in that female will be blocked because baby born is dead. There is no baby to suck the milk. In bad obstetric history, repeated abortions, to relax uterus, we use progesterone. Progesterone inhibits action of oxytocin on uterus, so that uterus will remain relaxed and pregnancy will be retained. Lactational amenorrhea, commonly asked question in the exam, what is the cause of lactational amenorrhea? Baby sucking breast, because of that prolactin level is too high. High prolactin inhibits GnRF. Hypothalamus is blocked for GnRF by high prolactin level. So there is no FSH, no LH, no ovarian changes. There are no sex hormones, so no menstruation. During lactation, high prolactin level inhibits GnRF, ovarian and uterine changes are blocked, and therefore there is no menstruation. However, this period should not be considered as a period of contraception, because accidental pregnancy can occur during this lactational amenorrhea. So couple is to be informed that they should not do intercourse without any method of contraception, otherwise pregnancy is likely to occur. They should not consider, as a misbelief is, till lactational amenorrhea is there, pregnancy will not occur. It is not true. Doctor will never recommend this as a method of contraception. They have to use some other method of contraception to prevent pregnancy. Coming to the last topic, and that is PCOD, which is a topic of interest for all young females. It is hyperandrogenic anovulation. Polycystic ovarian syndrome is hyperandrogenic anovulation. Itself indicates what is happening. Androgen levels are high and there are no ovarian changes. Ovulation is suffering. Ovulation is suffering and androgen levels are high. Incidence is too high, and probably now it is increasing. 5 to 10% of the population suffers from it. And age, not any age spared in the reproductive life of the female. Younger age group, more chance of getting PCOD. At a later age, less chance. More chances are at a younger age. Strong family tendency. If mother has got PCOS in her pubertal life, her daughter will also likely to develop PCOS. Familial tendency is seen. Sedentary lifestyle. High fatty, salty, carbohydrate rich diet. Lack of exercise, that is the main cause. Lack of exercise, sedentary life, rich junk food, fat, salt, carbohydrate rich food is associated with PCOS. It is always associated with obesity, and in future it is associated with type 2 diabetes. This is the symptomatology: irregular or no menstruation because of high androgen level coming from adrenal gland, excess body hair and facial hair, acne formation more in these females, pelvic pain because ovum is not getting released out of the follicle, and infertility because ovum is not coming into the fallopian tube. In every cycle, what is happening? Ovum is getting formed, but it is not getting released. So that follicle remains like that only, containing the fluid, and that develops the cyst. So every time one cyst is getting added to the ovary, and that's why the name polycystic ovarian syndrome. This is a diagnostic triad of PCOS. You do test of ovulation, and the report will be there is no ovulation. You can do basal body temperature, you can do ultrasonography, and you will come to know that ovulation is not occurring. Usually the young females, we don't subject them for D&C. We do it by other tests. We check the ovulation. If adult female is there, then one can go for D&C, but young girls, we don't subject them for endometrial biopsy. Blood androgen levels are found high, and by USG, we come to know that both the ovaries are full of cysts. This is a triad, diagnostic triad of polycystic ovarian syndrome. Many girls, I teach at almost 14 institutes as a visiting professor, and at most of the medical, paramedical courses, girls are more. Every year, about 50 to 60 girls report to me that they are having PCOS and what to do. I just tell them, you change your lifestyle. Do regular exercise. Exercise is the only treatment for PCOS, and diet restriction. Diet should be restricted for salt, sugar, fats. Regular 40 minutes tiring exercise is must, so that weight will be reduced. Directly related with weight. PCOS is directly related with weight. Once body weight comes down, automatically PCOS disappears. Oral contraceptive pills are recommended, but personally, I feel one should not go for hormonal therapy. Metformin is the drug of choice. It decreases appetite. It is actually an anti-diabetic drug in our allopathy. It decreases appetite, and because of that, obesity comes under the control. Anti-androgenic drugs are to be kept as a last treatment to suppress those androgens in the female. But the main thing is lifestyle modification, regular exercise, and diet. And remember, those who are having these polycystic ovarian syndrome, changes are totally reversible. Nothing to get the stress of that. Changes are totally reversible, but it needs lot of determination to do exercise and to have a diet restriction. Homeopathy has got lot of role in modifying hypothalamo-hypophysial-Gonadal axis. You must have been taught details of the history taking, and in homeopathy, details of the history and counseling of the patient is playing the most important role, which will rectify altered hypothalamo-hypophysial-Gonadal axis. You must be having so many homeopathic medications which are much superior than our hormone therapy. Hormones are always bad, and synthetic estrogens are carcinogenic for female. So at least I personally think twice before giving any hormone therapy for the female. But in homeopathy, so many medicines must be available. Without harmful effects of these hormone therapy, they must be serving the purpose. Infertility, impotence, stress management, all can be done better by homeopathic physician rather than a busy allopathic physician who will be immediately starting with HRT, hormone replacement therapy, which will in future will be bad for that female. So lot of role is there for all of you to look into these topics, go for the research, invent new and new medicines, and these cases will be under the control. Give best service to our society by your knowledge. I thank you all for attending the lecture. I thank again Dr. Page madam. Her entire team was literally active for almost last 1 week for this lecture. Similarly, Department of Physiology, Vichare madam and others, they made this lecture webinar a grand success. Thank you all of you.
Thank you so much, sir, for such an informative session. I hope all the audience is now happy and satisfied with this information. Now we will begin with the question answer session. So I request all the audience kindly drop your questions in the chat box so that sir can answer your question. Sir, we have some questions from the
Yes, madam.
students. Can I ask?
Yes, madam.
Okay. So question is there any physiological explanation how ovaries work alternately?
As I said, it is very difficult to understand a female, but a physiologist can give the explanation. Probably from cycle to cycle, FSH receptors on the ovary are changing. In one cycle, FSH receptors are more on left ovary, or rather one of the follicle in the left ovary. So that responds in that cycle. While FSH receptors, they increase in the follicle of the another ovary in the next cycle, and then that follicle responds. So it is probably FSH receptors are changing from cycle to cycle on both ovaries, and that's why ovaries work alternately. Similarly, out of so many secondary oocytes, how only one grows to form the ovum, what a physiology person can give explanation, all these secondary oocytes, they secrete estrogen. And estrogen receptors on one of the oocyte are more. So secreted estrogen from these oocytes, they cause growth of only one oocyte further, which has got more estrogen receptors by positive feedback mechanism, and that oocyte grows as a ovum. Well, on all other oocytes, estrogen receptors are not adequate, so they don't respond to the estrogen produced from them only, and because of that they degenerate. So it is probably the receptors for the hormones changing from cycle to cycle, receptors for estrogen on one of the oocyte that is responsible for one ovum formed per cycle.
Okay, thank you so much, sir. Another question. Can PCOS disappear during postpartum or lactation period, giving a false positive response to treatment?
Yes, it is quite possible. It is quite possible.
Okay, sir. Next is, which is the best and reliable test to detect ovulation?
Yes, usually what we do, we start with basal body temperature chart, especially if she's a young girl. We start with non-invasive tests like basal body temperature chart. For 3-4 months, we ask her to record her body temperature. If there is a slight rise in temperature noted at the middle of the cycle in those 3-4 month charts, we consider that she is ovulating. But if she is an adult female, then we can go for one more test, and that is ultrasonography. When we want to literally look into the ovaries, whether multiple cysts are there or not, for that ultrasonography will be done next. But truly speaking, that endometrial biopsy is unmatched. It is the 100% reliable test to detect ovulation, especially those females who are after marriage coming to the doctor for their infertility. The best test to do will be endometrial biopsy. And as I mentioned earlier, it has got a double advantage. Not only we detect ovulation, but we send same sample for tuberculosis checking, and that tuberculosis of the endometrium is the commonest cause of infertility in Indian population. So even that cause can be detected.
Thank you, sir. Another question. Why age of menarche is getting less in girls nowadays?
It is multifactorial in origin. Probably these young girls are getting more exposure to so much literature, and that literature, then information coming from friends, information they are getting on WhatsApp, Google, and all that, they all do affect their hypothalamo-hypophysial-gonadal axis. Similarly, more contact with the opposite sex at an early age also makes their puberty little early. So it is multifactorial in origin. As and when we are subjected to more urbanization and more gadgets are available to get the information, and sometimes I can say bad information, that do affect the age of puberty, and probably that is the reason why pubertal age is coming less and less.
Okay, thank you so much, sir. Next question. Can sperm antibodies cause infertility, which is the base test in that case?
Yes, sperm antibody, many a times what happens, that sperm count may be normal, but that male has got infertility. So someone is causing decrease in the function of the sperms, and it is probably because of, or it is an autoimmune response. Autoimmune response is getting developed, and that autoimmune response is probably causing decrease in the sperm motility. Sometimes that autoimmune response may even suppress seminiferous tubules for sperm count also. Testes are normally descended in the scrotum, all other things are normal, still sperm count is low, no mumps history, still sperm count is low. Then in that case, we suspect probably it is an autoimmune response. Or if sperm count is low but motility is less, then also we think of autoimmune response. And nowadays tests are available, though they are little costly. We can detect those autoimmune antibodies which are working against the seminiferous tubules or working against the sperms. So investigations are available to detect these autoantibodies.
Thank you, sir. Next is, can PCOS be diagnosed before menarche, as in delayed puberty?
Yes, it can be diagnosed. And that typical triad we mentioned, you do ultrasonography, you check blood androgen levels, and if periods are irregular, then one can look for, or if periods have not occurred, you can look for test for ovulation, because ovum is not getting released. Probably formation must be taking place. So she may not have started the menstruation, but ovarian changes must have started to little extent, that can be tested by test for ovulation. So it can be detected even at a younger age.
Thank you, sir. Next is, as HRT really useful in menopausal syndrome?
I personally feel that one should not go for it, because at that perimenopausal age, giving estrogens, exogenous estrogens, may be little risky, in the sense they are carcinogenic. Actually, truly speaking, for menopausal syndrome, no treatment is required. No treatment is required. The female has to accept aging, but that thing is very difficult. That thing is very difficult. Every birthday, their age decreases by 1 year. So if female accepts her aging, one should not go for HRT. Hormone replacement therapy is always bad in a long run. Unless symptoms are too severe, then only one can think of hormone replacement therapy.
Thank you, sir. Next one is, are there chances of women to conceive even with PCOD?
Yes, certainly. It is totally reversible. Totally reversible. So if she takes sort of treatment in the form of exercise and the diet restriction, ovulation starts. And once ovulation starts, she can conceive. Totally reversible. So many girls I know, my students suffering from PCOD, they're having now either one child or some are having even 2 children. They can conceive.
Next one is, why a female is diagnosed infertile and the cause remains idiopathic Then later after few years, she became pregnant. What changes could have probably happened?
Probably, madam, this has to do with our today's topic, hypothalamo-hypophysial-gonadal axis. If there is a lot of stress at home, if relations with in-laws are not good, all these factors, sometimes dietary factors, sometimes work conditions where she is working, doing the job, all these factors, they do affect hypothalamo-hypophysial-gonadal axis, and ovulation may suffer. And once those factors are removed, pregnancy is possible. I will tell you example from my department only, where I was working previously. One madam, she was our head of the department. She used to trouble everyone. She used to trouble everyone in the department. All young lecturers who got recently married, 3 years, 4 years working under her, were not conceiving only, getting a lot of investigations done. Then on one fine day, she retired and I became head of the department. And within next 2-3 years, everyone got child. It is because that mental stress was relieved and they could get the pregnancy. So mental stress is playing a most important role in that hypothalamo-hypophysial-gonadal axis.
Thank you so much, sir. Next one is, can fallopian tubal block corrected by surgery?
Nowadays, operations are available and many surgeons, they claim that if suppose tubectomy is done and afterwards that female wants that recanalization of the tube, or in male vasectomy is done and male wants recanalization of the vas, surgeries are there, surgeons are there, they tell confidently that I can join that tube. But the success rate is too poor. Success rate is hardly 5 to 10%, too low, because that fallopian tube lumen is too small. And when you do end-to-end anastomosis, either of the fallopian tube or vas deferens, it is that joint part is going to heal by fibrosis. And whenever there is a fibrosis, that small lumen, which is re-established, is bound to get blocked. And therefore, even though surgeries are there, they are having a very poor success rate. And that's why we say that tubal block is almost irreversible. Vas deferens block is almost irreversible, practically speaking.
Thank you so much, sir. I think all the questions are very well answered by the sir, and hope your doubts are clear. And if any more doubts you have, you can contact sir directly. Thank you so much, sir, for such a wonderful and knowledgeable session. Sir has very well cleared and explained hypothalamo-hypophysial-gonadal axis and its important role in pubertal changes in male and females, including their reproductive functions. Sir has very well explained how HHG axis is altered by endogenous and exogenous factors, resulting in infertility, impotence, and PCOS. Sir has very well cleared the clinical aspect and management of such cases. Thank you so much, sir.
Thank you.
Any event would not be completed without showing gratitude to all them who have involved in making this event successful. First of all, I extend my gratitude to our eminent speaker of the day, Dr. A.R. Joshi, sir, guest faculty of YMT Homeopathic Medical College, KHARGHAR, NAVI, Mumbai, for sharing with us a valuable information and guiding all of us about hypothalamo-hypophysial-gonadal axis. I would like to extend my gratitude to our esteemed chairman, Dr. G.D.POL, sir, for providing us platform to carry out such activities. I would also extend my gratitude to our principal, Dr. P.P. Page ma'am, for her constant support and guidance. I would like to extend my gratitude to Dr. D.G. Bagal, sir, Dean Faculty of Homeopathy, Maharashtra University of Health Sciences, Nashik, and Vice Principal of YMT Homeopathic Medical College, Navi Mumbai, KHARGHAR, for his constant motivation and encouragement. I would like to say thank you to the organizing committee and IT team for their combined efforts. I would like to say thank you to all the enthusiastic learners, including UG and PG students, all the teaching faculty and non-teaching staff of Dr. G.D.POL Foundation, YMT Homeopathic Medical College, Navi Mumbai. Now, we are concluding the today's webinar. Thank you all for patient listening. Have a great day. Thank you so much.